get started. There may be a few people joining us shortly, but I want to start so we can get through this wonderful content. Very happy today that Dr. Sheetal Gandotra has agreed to take time to put together this presentation on care of the critically ill patient with COVID-19. Dr. Gandotra comes from Saba University, where she did her medical school and residency at Rochester General Hospital. She completed a fellowship at Wake Forest before we recruited her here to join our pulmonary faculty in 2018. Since she's been here, I've had numerous residents tell me how much they've enjoyed her teaching in the ICU. And she has recently just gotten off of a stint of taking care of patients in our ICU. So she has plenty experience with this topic. So I want to thank her, and I will give her the floor.
Thanks so much, Ryan, and everyone else for taking the time to be here. I know it's busy times. So we'll go ahead and spend the next hour just talking a little bit about basics of COVID-19 and sort of some data, and then a little bit about the UAB experience as well. So here's just a quick outline. Like I said, we'll do a brief primer and then discuss the pathophysiology and some basics of epidemiology of COVID-19. And then most of our time will actually be spent discussing a case of Mr. Covey, his clinical presentation, the management decisions and outcomes. So a quick primer. As you know, COVID-19 really is the clinical syndrome that's reflected by a viral infection, SARS-CoV-2. So SARS-CoV-2 belongs to the family of coronaviruses. It was initially called novel coronavirus, but the WHO has subsequently renamed it to reflect some basic information about it in the name itself. And of course, to prevent some of the stigma that comes when you name viruses based on the location that they first originated. So as I was saying, belongs to a family of coronaviruses that also include others that we're familiar with, including SARS and MERS, and then common coronaviruses that usually cause colds. SARS-CoV-2 is a non-segmented single-stranded RNA virus with a protein envelope, and it's studded with spikes, which is what you've probably seen in a lot of the images that are circulating. We'll look at that in the next slide. The origin is likely thought to be bats, which then sort of infected pangolins as well and caused some abnormalities within the viral structure itself, and that's probably what has made it something that can infect humans. There is a very high transmissibility with an R0 of 2 to 3, meaning that each individual person that's infected can then infect another 2 to 3 individuals. And as I mentioned, COVID-19 is the clinical syndrome, SARS-CoV-2 is the virus, and so while they're used interchangeably, there is actually a distinction. So the basics of pathophysiology, as you can see, we described a protein envelope that's studded with spikes. These spikes are actually proteins on the surface of the coronavirus, and they bind to the ACE2 receptors on the surface of the target cells, which then leads to cleavage of the ACE2 receptor by a type 2 transmembrane serine protease, and this process activates the spike protein and facilitates viral entry into cells. So we won't spend too much time talking about pathophysiology, but I did want to actually show you a little bit about what's going on in the world. Hopefully you've seen the Johns Hopkins dashboard. I think it's one that I checked frequently as we were starting to hear more and more about COVID-19. I think now I more frequently look at the Alabama Department of Public Health dashboard, which actually has had some new updates. So if you haven't seen it lately, it now has case demographics and case characteristics that are pretty interesting. So I'd encourage you to check that out as a matter of interest. And then it actually does break down numbers by Jefferson County and all the other counties in Alabama, which is interesting to track and sort of see what's happening, particularly because I think our numbers here seem to have plateaued somewhat, but we're still seeing Alabama numbers rise. And so this tells me where those numbers are coming from and also what we're likely to see in the days ahead as we begin to take transfers and try and help out our colleagues elsewhere. So with that, let's move on to the next part of this talk, which really focuses around a case, the case of Mr. Kobe. So you're asked to come to the emergency room to evaluate this 55-year-old African-American male who presents to the ER for progressive shortness of breath that's been going on, he thinks, for about a week. And you're told all this by the ER resident who has seen the patient. The patient's been reporting a cough that's been going on for about a week as well, some fevers and chills maybe. He doesn't have a thermometer at home, so can't tell you his actual temperature. He does report some fatigue and myalgias, and he couldn't go to work, which is really what prompted him to come in. He works as a security guard at one of the local banks. As far as he knows, he doesn't have any sick contacts. His past medical history, per the ED, is only really notable for hypertension, for which he's on lisinopril. So they give you his MRN and you're able to look at his chart and you see his basic vitals. So he is febrile, he's tachycardic, and his O2 sats were 89% on room air. He's now 92% on 2 liters. He's tachypnic as well. His exam is mostly notable for him being tachycardic and tachypnic, but he's talking with really no issues. And his lung exam was clear to auscultation per the emergency room personnel. Other than that, they tell you that he really looks okay and not terrible. And then you can also see some basic labs that have been obtained on the right there. I'll give you a second to look at those. They've already done a chest x-ray for you, and you can see that there's a right lower lung zone opacity on the PA and the lateral, so you can tell he was well enough to go get a portable chest x-ray. So what next? We'll go through a series of questions that I hope you would consider as you thought about what to do with this patient. So the first is really, do you need to go down and examine this patient? In the pre-COVID era, absolutely. You would absolutely go down there, go in the room, take a full history from the patient, and do your own exam. Currently, however, there's a significant need to really minimize healthcare worker exposure and to conserve PPE. And so it behooves us to really limit our exams to when absolutely necessary. And that's really what we've been telling our teams as well. So trust your colleagues, ask a lot of questions of people that are going in the room, particularly nursing staff, as they have to go in the room when they're giving medications and assessments and things like that. So what you should do, though, is get any ancillary history you can from the patient. If they can talk, they can absolutely use a phone or the family member. Make sure to reassure them they're scared. And then, of course, like I said, use your colleagues, nursing, the ER staff, RT, and the attending if they're going in the room for physical assessments. Next, what's on your differential for this patient? So yes, the first thing on your differential is probably going to be COVID-19. However, don't forget all the other things that belong on your differential. So including things like bread and butter cap, maybe even PE if you hadn't seen the x-ray or you thought that this could potentially be a wedge infarct, and so forth. So there should still be many things on your differential, partly because even though we were initially hearing that patients sort of came in with a single etiology, the US experience and even some of the later data that's come out of China and other parts of the world really show that these patients can present with multiple problems. So I have seen patients with multiple other viral infections. We've had one person with H1N1, rhinoenterovirus, and strep pneumonia on bacterial cultures, as well as PCR positive for SARS-CoV-2. And the numbers really are somewhere around 6% of patients will have co-infections. So please do think about those other things as well. Oops, sorry, forgot to show you the next question there. And then thirdly, does the patient need admission? And if so, where? Right, the ED is calling you because they think the patient needs admission, but you also need to think about that. And I would say that this patient's hypoxic, so they probably should be admitted. I think that's one reason. Secondly, when we look at progression of disease later in this talk, I think this person's already demonstrating that they have some signs that may suggest severe disease. And so they definitely need to be admitted. They should be admitted in our facility to a COVID cohorted unit. And the question is, would that be on the floors or would that be in the ICU? So there's not great data right now for risk prediction at this point. So most of what you'll hear about this is all sort of expert opinion and guidance that's been developed at the institutional level. And we're all learning from each other, probably across the country and across the world. It seems like most institutions are using 6 liters as a somewhat arbitrary cutoff for what merits an ICU admission, as long as capacity allows. So here we're pretty fortunate in that we can offer critical care consults, and we've generally been doing that on the COVID floors if the oxygen needs are escalating rapidly or if there's someone that the teams are worried about. So I think in this case, with a person who's on 2 liters, did demonstrate improvement, clinically looks okay, I think they're probably safe to go to the floors, understanding that they're going to need to be closely monitored. So what other workup does this person need, and what other workups merited? I think, again, it's hard to know what's merited from a clinical standpoint, and if you ask a researcher, anybody that's interested in really looking at this disease and learning about this disease wants additional data. And so our power plan here consists of probably a mixture of what we absolutely need for clinical practice and then what we absolutely need to learn more about this and learn about risk prediction. And when we designed this, we really had a lot of conversations about where the right balance is to sort of think about cost, as well as things like blood shortages and not contributing to iatrogenic anemias. So currently the power plan consists of the testing shown on the right. All of it is optional, so you are not required to do any of it. We do recommend that if patients are being admitted to the ICU, that we at least obtain inflammatory markers on the day of admission and then at some interval, whether that be 3 days, 5 days, depending on what the disease course seems to be. On the floors, I think it's reasonable to get these on the day of admission as well. Certainly a CBC with differential, BMP, LFTs. The infectious workup is absolutely important. So the viral PCR, in addition to the actual SARS-CoV PCR, nasal swab, and then inflammatory markers. The ID group is very interested in the data showing associations with fungal infections, and that's why the Aspergillus galactomannan is on there. So I see a question about VBG. I think really at this point, unless there's some concern that you have about hypercapnia, I'm not sure that it's really going to change your management. I don't think it's unreasonable to acquire. I certainly would not get an ABG at this point. So the next question, and the one we'll spend the next several slides talking about, are really what are the clinical hallmarks of the COVID-19 syndrome? So one, briefly, transmission. This has really been looked at prior to everything that's going on with COVID-19. And this is just a quick reminder of how virus is expelled into the environment and can be transmitted. So there are small droplets which can travel as a cloud through the air and will generally travel further, up to 6 feet or further at times, and can absolutely aerosolize. So things like sneezing, coughing, even rapid talking have been shown to demonstrate potential for aerosolization. And then of course, large droplets can be generated by talking. These travel ballistically through the air and generally will fall to the floor or surfaces within a much shorter distance. Aerosolization can be produced by procedures like intubation or bronchoscopy, certainly things like induced sputum, so please don't do that on patients. And then by use of nebulizers, which is why we're also recommending that these not be the go-to for patients on the floors. So I actually found this really interesting, and if you haven't had a chance to look at this NEJM paper, Vandermellen et al. Created an experimental model whereby they tested the viability of SARS-CoV-2 on surfaces and in the air. So what you'll see here on the y-axis is titers, viral titers on these surfaces, and then time on the x-axis in hours for the next set of figures. So this is aerosols that we're looking at. And as you can see, SARS-CoV-2 remains viable in aerosol in the air for at least 3 hours, which was the duration of this study. This is similar. It was not significantly different to what's seen with SARS-CoV-1, which was the old SARS virus from several years ago now. And we'll look at other surfaces as well, and we'll sort of talk about why the transmissibility seems to be so different with SARS-CoV-2 compared to SARS-CoV-1. So what they found was on copper surfaces, there was viable SARS-CoV-2 for up to 4 hours, and then for cardboard, up to 24 hours. And then they also looked at stainless steel and plastics. And on those, SARS-CoV-2 is viable for about 72 hours. So the dashed line is the sort of marker for viability. And as you can see, in most cases, this is not significantly different from the SARS-CoV-1 virus. And so the authors really suggest that there are other characteristics of the SARS-CoV-2 virus that probably come from differences in perhaps viral loads in the upper respiratory tract and the potential for asymptomatic transmission. That's probably what explains the higher transmission rates. So we'll look next at some data that shows the most common signs and symptoms. This is from about 55,000 confirmed cases of COVID-19 that were reported in China. The data was collated by the Chinese CDC. And so as you can see here, about 80% of their cases had fevers. The next most common symptoms were dry cough and fatigue. Should be noted that in the Seattle case series that was recently published, it only had 24 patients, but only about 50% of those presented with fevers. So these aren't definitive, and I think patients present at differing time points in their course. So you shouldn't let any one of these really sort of deter you from thinking about COVID-19, the presence or absence of any one of these. And you'll notice that as our testing capacity has expanded, we've really learned for two reasons. One, I think we've become more liberal with our testing. So our testing went from you requiring travel history and a fever and a cough to really then being fever or cough or shortness of breath, removing travel history completely as we learned about community spread. And now, as you guys probably know, we're testing pretty much everybody in an effort to really understand more about what the disease prevalence is and who actually has it. And I will tell you, I was on service prior to us testing everybody, and I was absolutely surprised. The criteria of testing someone for fever or cough or shortness of breath meant that patients were tested who would not have otherwise been tested, right? So I may not have tested a patient who came in who was transferred, for example, for triple vessel disease, diagnosed at an outside facility, presented with a fever, and was actually only transferred for cabbage, but that patient was tested because of fever and the potential for going to the OR and was actually positive. There were several such cases, and so I think it's really good that we are testing broadly, and I would encourage you to really think in a very broad manner about who could potentially be positive. And some of that is now, at least at the main hospital, taken away since we are generally testing everybody. So the next thing we'll talk about is spectrum of disease. And just like there's a wide variety of symptoms, there's also a pretty wide spectrum of disease. So this is from the JAMA report of about 72,000 cases that were described by the Chinese CDC, published in February. So this is pretty early data. And they described about 81% of their population as having pretty mild symptoms. That's no or mild pneumonia. And I would imagine that these are patients that are predominantly in the community treated at home. Their next categorization was severe disease. So that seems like a pretty big sort of gap there, because it's hard to imagine that you have mild and severe. I really think there probably is a moderate, and I'll show you what the UAB designations are and what's being used more in the US as well shortly. So severe disease here was described as patients with dyspnea, hypoxia, or over 50% lung involvement on imaging within 24 to 48 hours. That was about 14% of their cases, and then only about 5% of their cases had critical disease, which was respiratory failure, shock, or multi-organ failure. So at UAB and really across the US and other places in the world, we've sort of categorized patients as being asymptomatic. So those that are confirmed with SARS-CoV-2 but really don't have any symptoms. We'll probably pick up more of these as we have broader testing availability. And then mild disease, which are patients that are febrile, may have cough or cold symptoms. These patients often have normal chest imaging and really no significant shortness of breath. And then we do have a moderate categorization for hospitalized patients. These patients may actually have some degree of hypoxia, but can frequently be managed on the floors, and they will generally have some chest x-ray findings or chest CT findings. And then severe are really those patients that are managed in an ICU. So this is from the UAB treatment guidance table, and we'll look at that in its full content later in the talk. So radiographic patterns, as I've sort of referred to already, vary widely. Chest x-ray is often normal in mild disease, but can evolve through the course of illness. That doesn't mean we should obtain daily chest x-rays. And in fact, we are deterring people from obtaining frequent chest x-rays, particularly if it's not going to change your clinical management. Then there's absolutely no reason to expose another person and use the extra PPE. A chest CT is absolutely not necessary in all patients. We saw a lot of data initially coming out of China and I think even Italy about chest CT patterns and sort of, being pathognomonic for disease. And I don't think we're actually there. I think the variability of what we see on chest CTs is not going to tell you, yes, this is COVID, nor is it going to change your management. So the only time I'd really say that a chest CT is valuable is if your hypoxia is disproportional to chest x-ray findings or to the clinical situation. And then if I really think it's going to change management. So if I have a relatively normal looking chest x-ray, but somebody that is intubated and now requiring, a significant amount of oxygen support, but doesn't demonstrate the other usual things we see with ARDS, I may actually, think that a CTA is valuable. And then I really need to consider whether they're safe to scan, both from an oxygen need standpoint, from a hemodynamic standpoint. Do I have the staffing and the PPE that's necessary to get them to the scanner safely? And does the CT scanner have a safe process for then cleaning the room so that the next patient isn't inadvertently exposed? And a lot of that stuff's been taken care of in the background, but it's stuff that, we should think about before we send people for testing. And if you're at another institution, for example, those are things that you may need to work on or consider or create a process for. So I will show you some of the variable findings that you can see on chest CT. These are from 4 different patients at 4 different time points in their disease processes. And as you can see everything from pleural effusions in panel D there to really just some peripheral ground glass in panel B to more dense infiltrates in panel C, and then a very, very faint, subtle finding that represents ground glass in panel A and some interlobular septal thickening that you really do have to look for and would probably need some additional cuts to be able to demonstrate. I just didn't have the space to show you all of them. So some common lab abnormalities, AKI seems to be fairly common in this population. Probably the most common lab abnormality that's been reported is lymphopenia. And then, by extension, leukopenia as well, thrombocytopenia, AST, ALT, elevations are common, not to the point where you would be thinking about shock liver or, toxic injuries to the liver, but certainly some elevation beyond normal is what's being seen. there's not great descriptions of what proportions of the population. I've seen numbers about like 80% of the population for lymphopenia, but the others, it seems like it's a pretty wide variety of what we see. I will say, having been on service, the vast majority of the patients who came into the ICU did have those lab abnormalities. So back to Mr. Covey. You're looking at his chart the next morning, and you notice a few things. So some of the additional labs you'd ordered are now back. His CBC is similar. He is lymphopenic on the differential. His BMP and LFTs are similar to what we had talked about. And then he's now on 4 liters with SATs in the 90% range. His SARS-CoV-2 PCR is positive. His viral PCR is also positive for rhinoenterovirus. And then you can see that he's got elevations in his ferritin levels, his ESR and CRP, D-dimer, LDH, but his lactate is normal. I see a question about empiric anticoagulation. I'll address that towards the end of the talk, but the short answer there is, I think I wouldn't do anything different for COVID-19 disease. So if my suspicion for PE is high, then I think it is fair to put a patient on heparin, granted that they don't have any other any other contraindications to anticoagulation. I think that if your suspicion is really on the low or intermediate range, then you shouldn't do that. If your suspicion's high and you don't think they're safe to scan, then absolutely go ahead and anticoagulate them as you would in any other patient. I'm not sure that I would do it just to preserve PPE and reduce exposure, though. All right, so I think also being asked, are you finding patients with symptoms of air hunger having normal O2 saturation? So we absolutely are seeing patients that are very tachypnic and air hungry in the ICUs as well. I imagine, it sounds like on the floors the same is true, and but in the ICUs, it's something we've commented on. Our patients are often very tachypnic, but they'll look okay. And so that makes it much harder to try and decide when to intubate someone, particularly if their saturations aren't terrible. And we'll talk about that a little bit more as well. So what next for Mr. Covey? Well, at UAB, I think this would be the appropriate time for a critical care consult. His oxygen needs have increased, and certainly he has some markers suggestive of severe disease. So what are the risk factors for severe disease? We'll look at that next, and we'll also look at what the disease course is for COVID-19 as best as we understand it at this point. And then thirdly, what do you do with all these labs, right? Because I've talked a lot about doing things that will change your management. We just did a whole bunch of labs, and what are we going to do with them? So this is more data, early data, from confirmed patients in China. This was, I think, their initial population that we talked about in a prior slide, and what it demonstrates is the case fatality rates by underlying health conditions. So as you can tell, the most common underlying health condition in those that died was cardiovascular disease. Next was diabetes, and then chronic respiratory disease and hypertension. We haven't seen a lot of mortality here, and I'll get to that towards the end of the talk, but I will say the patients that we're seeing present are the ones with underlying health conditions. Predominantly hypertension, diabetes seem to be quite common. We're not seeing as many of our chronic respiratory disease patients as we thought we would. We think that might be because they're very used to isolating and doing very good sort of personal hygiene measures and things like that in flu season, and so they may have been early adopters of that. We don't really have a good reason for why we're not seeing as many as we expected, given that we are an ILD center and we have a lot of patients with chronic respiratory diseases. So the group at MGH actually did a really nice job of creating a table of risk factors for severe COVID-19 disease. And I'd encourage you to check out their resource website. It's got a lot of information, and they actually have references for each of these as well. But there are some epidemiological risk factors that for severe COVID disease. So this is not just for being infected, but for developing severe disease. So age, absolutely, you've probably heard a lot about that. Pre-existing pulmonary disease, chronic kidney disease, diabetes, as we mentioned, and hypertension, cardiovascular disease. Immunosuppression is on the list, and so is uncontrolled HIV. I can't say that we've seen enough patients to really see that population yet, at least. So in terms of vital signs, being tachypnic is a risk factor for severe COVID-19 disease. This fits with what we've seen clinically as well. Tachycardia seems common, and then hypoxia absolutely seems to be a harbinger of more severe disease. And then in terms of lab values, this is where some of the power plan comes from. So there is data that we'll look at next, that there are lab trends that suggest more severe disease. And actually there's even a group that's looked at separating out survivors and non-survivors. So D-dimer levels above 1,000, CK levels that are elevated twice the upper limit of normal, and elevated CRPs as well. And then the low absolute lymphocyte count seem to be associated with more severe disease, as we've mentioned several times. We don't recommend getting troponins routinely unless you have a clinical need to do so, but there are studies that have demonstrated elevated troponins are associated with severe disease. Part of the reason to not recommend them without clinical symptoms is because then you're left with a lab value, and you're really sort of put in that position of deciding what to do with it, right? Are you going to now call cardiology to ask, and do you need to? I don't think we know enough about this to really say that it's going to change our clinical practice. And so we don't routinely do it unless, of course, the patient is having symptoms. So just a different way to look at age as a risk factor for disease severity. This is also out of the CDC, and it's fairly early data. It's the mortality morbidity weekly report for data in the US from February 12th to March 16th. And on the y-axis, what you see is number of hospitalizations, ICU admissions, and deaths. And remember, this is pretty early, which is why the numbers aren't as high as one would expect. And then they've broken down on the x-axis by age groups. So you can see that hospitalizations are occurring across the age group. I think that's consistent with what I'm seeing reported at the UAB system, although I have to say my view is, of course, skewed by what I'm seeing in the ICU. And we're certainly seeing that middle age 50 plus population for most of our patients. ICU admissions become more common the older we get, and then deaths, as you can tell, are mostly affecting patients above the age of 55. All right, let me take a quick look at the chat. So clotting on CRRT, even after switching to systemic heparin. So antithrombin 3 deficiency, there's actually a paper out in, I think it's the NEJM from a couple of days ago, and Pulmonary actually has a talk about coagulopathies in COVID-19 patients today. So I think so far we've put one patient on bivalirudin, but for low for antithrombin 3 deficiency with the guidance of hematology, I don't think that we necessarily would recommend doing it routinely. I don't think there's the data to do that right now. And we, as a group at UAB, I'll talk a little bit about the treatment committee, but as a multidisciplinary group, it seems like most of us agree that the things we should do should be somewhat evidence-based. And what we need to do is treat what we're seeing, the clinical syndrome that we're seeing. And right now we're treating that as other viral pneumonias and other viral associated ARDSs. So whether we will change our recommendations will absolutely depend on what comes from data in the rest of the country and the rest of the world. All right, so COVID-19 disease course. This is actually from a grand rounds, and I haven't seen the primary literature for this, or the primary sort of paper that had this figure in it, but I thought it was a great figure, and it demonstrates really the disease course, and on the same figure, the viral load, and how it's different from what we know so far in patients with typical disease, fatal disease, and severe disease up at the top there. So as you can tell, there is an incubation period. The median incubation period is about 5 days, but the range is probably somewhere up to 14 days. The acute mild phase seems to range from 5 to 10 days, and then really the more severe phase of disease, ARDS, the pro-inflammatory phase, seems to occur at the 1 week plus mark. So I would say the vast majority of the ICU patients that I had last week really presented a week, 7, 10 days into their disease course. And in my 1 week, I proned 4 or 5 patients, which is higher than what we normally do. So certainly we're seeing severe disease, but we're seeing it present along this timeline. The acute mild phase is probably what is in the community, I would think, and maybe some of that is what's presenting on the floors when they're hypoxic as well. And then, of course, recovery. It's unclear right now how long exactly you shed virus for and how long it's taking people to recover. It certainly seems from the ICU population that this is a very long time period to recovery. So we have had people now that are on vents for coming up on 2 weeks. Slow improvements or sort of stagnated as of a couple days ago at least. So I mentioned that there's a group that's looked at temporal changes and lab markers. This is worth looking at out of Lancet, published recently, as is everything in this talk, so I should probably stop saying that. So what you'll see is several different lab values trended over days from illness onset on the x-axis. So the first one there is D-dimer. And red delineates non-survivors, blue delineates survivors in all of the figures on this slide. So as you can tell, non-survivors really seem to have significantly elevated D-dimers throughout their course. Lymphocyte counts are lower in non-survivors in the population, at least, that Zhao et al. Looked at. And this is the population from Wuhan, China. So this is about 200 patients that they were able to do this for. IL-6 seems to also differentiate survivors from non-survivors, particularly when levels are elevated, after that 2-week mark of disease. And then similarly, ferritin levels are significantly higher in non-survivors as well. Same with CRP levels, although there's much more variability in CRP levels than we're seeing in some of these other lab values. And then same with LDH. And again, these lab values are particularly helpful when you look at trends. And so this is part of the dilemma of what do we recommend for getting and what is the right balance? And does it really help us prognosticate if we're not able to see a full trend up front? So Mr. Covey has moved to the ICU. What are some key things that I think should happen at this point? And this is just, again, mostly expert opinion and what we're recommending here. So one, definitely notify the family. So remember that we're not, we don't have visitors for these patients in the hospital. And I think I can't even begin to imagine how distressing that must be for families, but it is particularly distressing if your family member is not on the floor when you call the floor, because you will imagine the worst. And this is not just specific to COVID-19, but absolutely, please call family members with changes in clinical course and certainly with any transfers. And then really, you probably should ask for a negative pressure room in the ICU, or at least one where a HEPA filter or scrubber can be placed, because the potential course of this patient is that they are going to require intubation, which is an aerosol generating procedure. And so the recommendation is to have a negative pressure room. The transport team, the recommendations here are 2 people in standard PPE, and then most important, 1 without PPE to actually hit buttons and open non-automatic doors. So not stuff we normally think about, but for 2 reasons. 1, conservation, 2, limiting potential transmission. The patient wears a surgical or droplet mask. And I guess I should say our patients are being asked to wear one of these masks every time someone is in the room with them. So the next portion of this talk will focus on management strategies, and I see that there's some questions for HLH and whether we're checking for hypertriglyceridemia and splenomegaly and sort of other markers for HLH. We are not routinely recommending checking. In reality, by the time your patient's intubated, and if they have any of these elevated inflammatory markers, they will meet what has been put forth as a definition for HLH, and they'll probably be classified under like severe cytokine release syndrome. But I don't think the data exists right now to really recommend treatment based on those, particularly when the etiology is an infectious process. And so we have not been recommending it routinely. So the basics when your patient's in the ICU is empiric antibiotics. I think those are reasonable at this point, particularly with what we know about co-infections. There are some data that suggest a very elevated procalcitonin level can still be indicative of a bacterial superimposed infection. I think this is also reasonable on floor patients that are hypoxic, or have other markers where they may have severe disease or perhaps co-infections. Minimizing volume resuscitation has been recommended across the board. I think, fever control has been recommended. I'm not sure that there's significant data to support that. That's probably true in general critical care practice as well. And then with regards to bronchodilators, only if there's an indication. So history of asthma, COPD, chronic use, wheezing that you think is non-cardiac would certainly be reasonable, but we do recommend using MDIs and not nebulizers. So at this point with Mr. Covey, it certainly seems like he might be transitioning into the sort of more severe portion of his disease course, probably trending towards ARDS, and that's what I'd be worried about. So what are my other options prior to intubating him? And I see that there are some questions about intubation. So high flow nasal cannula, you've probably heard that there were initially a lot of concerns about increased viral transmission, but these are not evidence-based, at least when it's been looked at in the pre-COVID era. And so we have relaxed our guidelines on these. The WHO guidelines or surviving sepsis guidelines that are specific to COVID-19, as well as the ANZIX guidelines for COVID-19 actually do recommend the use of high flow nasal cannula as a therapy for hypoxia in these patients. The rationale is that high flow nasal cannula provides about 40 to 60 liters per minute of flow, but normal cough will achieve flows of 400 liters per minute. And so you can decrease exposure. So the hope is that we can decrease exposure to healthcare workers by avoiding intubations. And there's data from the FLORA-LEE trial for the utility of high flow nasal cannula and ARDS. So we are saying yes, high flow nasal cannula is an option. We tend to do lower flows and the patient wears a mask. Non-invasive positive pressure BiPAP. So I'm not going to go through the FLORA-LEE trial, but there's data to use BiPAP in ARDS patients, but there were several reasons to avoid in COVID-19 patients, largely coming from data in MERS, where 92% of patients failed and required emergent intubation. We're really trying to avoid emergent intubations. Awake proning is something you'll probably hear more about. It's the same physiology as in a patient on invasive ventilation, and there is anecdotal experience from Jiangzhou in China, where they did extensive awake proning and had much better outcomes than the other areas of China. So we are trying to do this. We're hoping to do this in a trial format, as long as we can do it as a waiver of consent. So this was the protocol used by the group in the Jiangzhou hospital in China. So this is if a patient can prone themselves, no extra PPE, no extra instructions, really very minimal resource utilization. And from my perspective, very little harm. So we do now have a protocol for doing this at UAB. I did this twice during my week. It worked great for oxygenation. Unfortunately, in neither of those two patients was I able to actually prevent intubation on subsequent days. So Mr. Covey is now 10 days into his illness. He's on high flow nasal cannula at 60%. He was encouraged to prone and his saturation's improved, but now he's supine again and his sats are 88% on 60%. his inflammatory labs are continuing to uptrend, and he's still lymphopenic. So I think the question is when to intubate. Certainly, we have a lower threshold for intubation than usual. For a number of reasons. You want to have time for PPE, and these patients have silent hypoxemia, so their workup breathing isn't always going to be reliable. And then patients can develop worsening atelectasis and very rapidly decline. And then, of course, we want to avoid bag valve mask ventilation during intubation. And so you need some pre-oxygenation ability, and you're going to do that using a non-rebreather for the most part. And so that's probably why we do early intubate in these patients. So I would say that if you have progressively rising FiO2 requirements, as Mr. Covey does, increased work of breathing or clinical distress, and then certainly an absolute high oxygen requirement, we've sort of been using 60-70% as our general guide to start prepping for intubation. We are very aggressive in telling patients and family members about the potential for intubation when they move to the ICU, so that this is not a surprise, particularly when families can't be there. So intubation best practices, you guys don't necessarily do this, but I put it in here as a reference. You need to plan early. Everything needs to be done outside the room in terms of preparation. And then pre-oxygenation with non-rebreather, the recommendations are to use video laryngoscopy and rapid sequence intubation to minimize exposure to healthcare workers. I think probably the coolest part is all the innovation that has come with COVID-19. And so there are groups that are developing boxes to help minimize aerosolization exposure to the intubator. And then certainly you absolutely need a viral filter if a patient is getting bagged. And then anybody that's being bagged needs a two-handed seal, is what we're telling our fellows. So the patient's safely intubated. And at this point, really what you need to do is excellent critical care for ARDS. So all of the standard things that we talk to you guys about when you're in the ICU. They absolutely should get an EBG at this point. They do need an X-ray for ET tube placement unless you're savvy enough with POCUS to be able to do this. There is a protocol for that. Most of us aren't using that right now. And then it's reasonable at this point to get a tracheal aspirate. We're avoiding bronchoscopy or BAL unless it's absolutely necessary, and then no unnecessary trips out of the ICU. I think you have to ask yourself, is this patient's disease consistent with ARDS based on the Berlin criteria? And I won't go through this. This is a reminder. And there is, and you'll start to hear more, I think, about how COVID-19 may not be a classic ARDS, which is demonstrated by decreased compliance. And in some of these patients, I think someone brought it up in the chat, we're not really seeing that. I have to say, at the UAB sort of patient population, we are seeing classic ARDS. We're seeing patients respond to our standard management and to proning. But I put this here so that you would have it as a reference. Gattinoni talks about the two different types of ARDS that they're seeing, one with normal compliance, one with poor compliance. Patients with poor compliance are classic ARDS. They're the ones that respond to PEEP. And for us, still the majority of our patients. Patients with this type L or normal compliance may actually do worse with mechanical ventilation and certainly worse with high PEEP levels. And so they may be the ones that get proned. They do still respond to proning, but may not get the same high PEEP levels. This is a quick summary for you for ARDS management that I won't go through. Several questions were asked about whether we're seeing shock or hypotension or cytokine release syndrome. I think these all sort of merge together somewhat, and what you need to do is support with vasopressors. Our experience is that we're not seeing the sort of rapid come in with shock and die patient population right now. We're mostly seeing pressor needs that are evolving as we're heavily sedating patients in order to achieve vent synchrony and proning. I think at this point, if they are in shock or hypotensive, this would be the time I'd consider troponins and an echo or a POCUS exam at the very least. And then at this point, please discontinue antihypertensives. Nobody's asked right now, but there are no recommendations right now to discontinue ACEs or ARBs on patients that are already on them if they come into the floors. About 5% of patients will develop AKI. So some COVID-19 specific management, bundle care, limit staff time in the rooms, telecarts, we're fortunate to have these, so please use them. And then there's really very little quality of data to support pharmacologic therapies, aside from really the trials that are running at UAB. The recommendations from all of the societies that have been put forth so far to avoid steroids unless there's an alternative indication. There is a treatment committee at UAB that's come up with this treatment guidance. I won't go through this, but it is available on the one page for you to look at. We tried to be as evidence-based as we could be. As far as I knew from last week, nobody here had received tocilizumab. We do have several patients in the remdesivir clinical trial. A few have received hydroxychloroquine, but I think mostly everybody in the critical care group has been very reluctant to recommend hydroxychloroquine or many of these other therapies, given that we are not seeing the mortality rates that are being seen in other parts of the world or the country. There are many other therapies in the pipeline. We will have a trial on inhaled nitric oxide. And I think there's some effort for us being part of a convalescent plasma study, although I haven't heard when that would start. And then similarly with the hydroxychloroquine trial. ECMO at UAB, we are offering it. It is high resource utilization, and we're using the same criteria that have been used for other ARDS patients. There's only, I think there's 2 patients. One is a transplant patient that we were not involved with, and the second is a patient who failed conventional treatment for ARDS and is now on ECMO. Lots of questions about cytokine storm. I don't have a whole lot to say about it other than there isn't strong data in adults to support the routine use of immunosuppressives when the etiology is infectious. And so most of us are not recommending it. We are not seeing the cardiogenic shock and arrhythmia deaths so far, at least. So will Mr. Covey recover? I think additional organ failures as they develop make recovery less likely. And then if he does, we expect long hospitalizations and post-ICU complications. I don't think this is very different for COVID compared to other ARDSs. There have been efforts to separate out, as I showed you earlier, survivors from non-survivors with symptoms. I don't know that anything in terms of symptoms helps me based on these figures. What does probably help is development of other organ failures. So acute kidney injury, acute cardiac injury, and then any secondary infections are certainly poor prognostic indicators. Similarly, the Seattle group published their 24 patients, about 50% of them had died at the 14-day mark, which is unfortunate. We haven't seen that mortality. And I think one of the reasons that we think that's the case is that our system had a lot of ability to absorb these patients. We canceled elective procedures. We were able to double our ICU teams both during the day and at night. And so we have an opportunity to really do typical good evidence-based critical care. We've been able to prone. We now have proning in the CCU in addition to the MICU. And so I think most of us feel that either we didn't have our healthcare system really overwhelmed. Places like New York, which I can speak to because I've spent some time working in that system, they operate underserviced on their best days. When I was there as a student or as a rotating resident, you take patients for testing on your own, you do your own blood work, all that sort of stuff speaks to a system that is very overwhelmed on its best days. And so when they got the numbers of ill people that they did very rapidly, there's just no way that you can do some of these high intensity critical care interventions, things that patients here seem to be responding to. I don't have another reason for why we're not seeing the cardiogenic deaths or the sort of super high mortality. I think we've had 7 deaths out of 130 patients is the most recent number I've seen. Several of those were related to multi-trauma and not to severity of disease from COVID. So a quick summary, do your part to flatten the curve, always wear appropriate PPE. I cannot stress that enough. For those of you that are, working with COVID patients, and for those of you that we did training for, it is incredibly important to make sure you wear PPE. No different than assessing a scene of an accident before you go onto it to help someone else, or putting on your own oxygen mask in an airplane before you help someone else. Severity of illness varies. The age and chronic illnesses seem to beget risk for severe disease, and outcomes, I think, really remain unknown. And we need to see what differentiates us from other parts of the country. And then lastly, these are times of higher than average stress levels, so be kind to yourself and to others. I added a couple resource slides at the end just that I think are super helpful, and then a couple additional resources. Sorry, I went a little longer than I expected, but I'm certainly happy to take questions and any that I missed.
So we're at the 1 o'clock hour. If Sheetal has time, I'll let her stay around for just a little bit longer. Anyone that has to sign off, we certainly understand. I'll let you read the chat, Sheetal, just for a minute and just kind of see what else you would like to comment on. And I'll just make a couple comments. I appreciate all of the questions from very thoughtful residents about the different emerging treatments. I will say, from talking to colleagues around the country, different places are all trying lots of different things. So one of my colleagues at Columbia, New York, said they're putting a lot of their patients on empiric anticoagulation. Another colleague at UT Southwestern said they're big in the TOSI trial. I think here the point is really we just haven't had the mortality a lot of places have had. And so if we just hang tight, focus on good critical care management, and first do no harm and wait for a lot of data to come out. So I think probably in the next 4 to 6 weeks, we're going to start to get a lot more randomized data, and then we'll really be able to see which of these therapies are potentially helpful and which are harmful. So hopefully, Sheetal, I stalled for you just for a minute so you can answer any questions from the chat you would like now.
Absolutely, and I wholeheartedly agree. Do no harm has to come first, and that's really been the theme that at least pulmonary critical care has put forth. I think it's very hard to watch the mortality that our colleagues in New York and Seattle and Italy have seen, and feel like you're doing nothing. And I think in the pulmonary critical care world, we are very used to the idea of do no harm first. And I have a mentor who always said that standing and watching is sometimes the most valuable thing you can do for a patient. And so I have to remind myself of that, and remind myself that we don't have the mortality of these other places. And our system is fortunately not overwhelmed, and we should take advantage of that. So thoughts on empiric diuretic use? Yes, absolutely. Pulmonary critical care and intensivists love diuretics. Absolutely try and keep them net negative, just like you would with other ARDS patients. Certainly, I think that needs to come with clinical assessment. And so please don't use that as an absolute requirement, but use your clinical judgment and certainly trend towards negative fluid balance. Should you encourage patients on the floors? I don't think there's any reason not to do that. We are trying to get ourselves into a pragmatic clinical trial so that we would be able to offer this and study it, so that we actually know whether it's worth being one more thing you recommend to a patient. But I think in the meantime, it's certainly reasonable to try, and probably has very little resource utility or harm to a patient. All you have to be careful about is their IVs and that they have enough space to actually turn in bed. And the protocol is available on the one page that we've designed. Not more proning questions. Geopresa, so we've used it in one patient that did seem to have very bad shock. And that patient was very responsive, but it's an N of 1 and totally anecdotal, and I have not seen any other data on that. So I would use it no differently than you do in other patients with shock right now. So again, yeah, I think, Dr. Heath, I think that comment about higher death rates in other parts of Alabama is absolutely concerning. I mean, normally we take all of their patients. We try really hard, actually, to be very open to other facilities. And we absolutely appreciate that they can't prone. We are doing tele-ICU at all 5 or 6 sites that we're able to. This is not the time for institutions to sort of rapidly develop proning teams. This takes a while and it can be harmful. And in centers that are not comfortable doing it, there are complications. And so we have not been recommending that places who don't comfortably prone now magically try and get their staff to prone these super sick patients. Given that we now have capacity, last I heard, we are trying to help by taking some of their patients. I absolutely think that their mortality is probably reflective of the same issues in New York. Their systems are being overwhelmed. There's also, it seems like, at least from the Alabama dashboard, that there's probably more healthcare worker exposure there. And from what we saw on our telemedicine visits, the utility of PPE was very concerning, or the lack of PPE that was being used was very concerning. Now, I don't know if that's an education issue or a resource issue, and we've offered help for the centers that, you know, we work with. And absolutely, some of these small centers have like 13 beds that are never full, and now they're absolutely full and they're calling us for help. So I do think mortality is associated to overwhelming of systems. APRV, so it's not something we commonly use. It's absolutely something that is being tried in other centers. I have friends in upstate New York that use APRV for all of their ARDS patients. And so they're seeing, you know, they're anecdotally having success with the patients they're seeing up there. They're also a system that's not overwhelmed though. And so their volume of patients is very low. I think if I had a patient with that low elastance phenotype, I'd probably be willing to try it. But again, something you want to make sure your RT is comfortable with and your team is comfortable with. I think I caught all of the questions. Absolutely feel free to email me or ask. Oh, a question about retesting. That's actually a really good question from Lindsay. We are now being allowed to retest patients who have high clinical suspicion but had an initial negative. I think particularly if they were negative at an earlier time point in their disease, and now they're developing much more severe sort of symptoms that fit with the COVID-19 syndrome, it's reasonable to retest. And I think you now can do that without having to go through ID or infection prevention. Yes, I can absolutely share the slides. I love that quote. They also serve who only stand and wait. Absolutely. I think we need to remember that. And I also think that, you know, a lot of the treatment committee is not people who generally spend a lot of time in the ICU. And so it's very hard, unless they're hearing our numbers regularly and sort of seeing our numbers, to realize that we're not there. And so we, you know, we can probably do the best for our patients by waiting for evidence, unless something really changes or moves us to do something differently. Our contingency plans. So there are lots of contingency plans. I have to say, from talking to colleagues across the country, we are incredibly fortunate, and I feel like we have planned incredibly well. We were behind the curve with our cases. We had an opportunity to plan for a surge. We had, I mean, the number of times we've changed our schedule is impressive. And, you know, the number of times you guys have changed your schedule to accommodate what we are doing is also impressive. And so I think we're very fortunate. There is absolutely a contingency plan with the cancellation of elective procedures, as well as an ability to do things like alter our BiPAP machines so that they can be used for, you know, the types of ventilation required for ARDS patients. Jim Johnson has worked with the engineering group to do some of this. And so I think we're in a good position for ventilator management unless something really dramatically changed. And we have actually supported some of our other hospitals with our older ventilators. And so I think that behooves us to do when we know that we are in a much better position than our colleagues within the state. I think that was, I'm trying to see if I'm missing anything more recent.
I think that's it. Thank you so much, Dr. Gandotra. We really appreciate all of the time you spent preparing this talk and taking care of our critically ill patients.
Absolutely. Thanks for having me.
Okay, everyone. Bye now.
Bye, guys. I'll stay on in case anyone has a question.